Hello, I would like to welcome you to our Clinical Teaching on the Run series for doctors. These online presentations provide an overview of the core information that we cover in our face-to-face series. I am Dr. Sadownik, and I will be walking you through this presentation. So let's get started. In session 1, we discussed a philosophy of teaching that would help you become a more efficient and effective clinical teacher. In particular, we discussed how inspiring learners and involving them in your patient care is more important than lecturing them or passing on information in the clinical setting. In session 2, we discussed practical, time-saving teaching strategies. In our last session, session 3, we discussed how to facilitate the diagnostic reasoning skills of our learners. Today, we will focus on how to facilitate their therapeutic reasoning skills. Our goals today are first to define therapeutic reasoning, secondly, to apply a framework or a series of questions to guide our learners through the steps of therapeutic reasoning, and thirdly, to compare and contrast how specific teaching strategies can be used to facilitate therapeutic reasoning. So to review, clinical reasoning is defined as the cognitive thinking process whereby a physician gathers appropriate data, arrives at a diagnosis, identifies a treatment of choice, and then gives a reasoned recommendation to the patient. Diagnostic reasoning refers to the analysis of the patient's data to ultimately arrive at a working clinical diagnosis. In contrast, therapeutic reasoning refers specifically to the steps whereby treatment options are analyzed and a treatment of choice is identified. The thoughtful analysis of treatment options includes the following reflection. First, one considers what would happen without any medical intervention. Then one identifies all treatment options. One analyzes these options. And finally, one decides upon a treatment of choice. Let's walk through this framework with a clinical example. As I'm a gynecologist, I will use an example of an 18-year-old woman who presents to my clinic with an abnormal pap smear. The learner presents the following. This is an 18-year-old woman. Her pap smear reported a high-grade squamous intraepithelial lesion. The colposcopic impression was the same, and the biopsy confirms the diagnosis of a high-grade squamous intraepithelial lesion. The preceptor may begin by asking about the natural history of the disease. Ask the learner, well, what will happen if we do nothing? Next, the preceptor will ask the learner to list the treatment options and describe these options in regards to the likelihood of success, benefits to the patient, common side effects, and/or risks to the patient. The preceptor may ask the learner to compare all of the treatment options or limit the discussion to 2 or 3 of the treatment options. Finally, the preceptor asks for a recommendation and reasons for this recommendation. Of course, this looks familiar because it mirrors the steps of obtaining an informed consent from the patient. It is important to note that the informed consent can be taught, role modeled, and observed. I would like to introduce you to the RHYME framework. It is an approach to evaluating the performance of learners. It can also be used for setting learning goals or expectations of performance. In the session on diagnostic reasoning, we discussed how learners often feel comfortable in the role of reporter. They collect and then report the information obtained from the patient's history, physical examination, and/or investigations. They report the what facts about the patient. For example, what did you find on physical examination? We then discussed how important it was to use questions to get the learner to start to interpret these facts. Now we want to use questions to move the learner beyond interpretation of the patient's findings onto management of the patient. We would also like senior learners to move beyond managing the patient to critically assessing their management options by educating themselves and others about the optimal management for the patient. Okay, let us return to my clinical scenario to illustrate the different levels of therapeutic reasoning. I introduced you to an 18-year-old woman with a diagnosis of a high-grade squamous intraepithelial lesion on her cervix. So the preceptor asked the junior resident, "What will happen if we do nothing?" The junior resident replies, "If untreated, there is a risk you will get cervical cancer." The preceptor reviews the treatment options with the resident and asks for a final recommendation, and the resident recommends a surgical intervention. They believe it has a high success rate. Let's compare this with the senior resident's responses. The preceptor asks, "What will happen if we do nothing?" And the senior resident, who has analyzed the latest literature about the natural history of this disease in young women under 21, concludes that the risk is actually very low that she will develop a cervical cancer, especially in the short term. Thus, their final recommendation is close follow-up, not surgical intervention. So while the junior resident is technically correct that the standard treatment for a woman presenting with a precancer lesion of the cervix is surgical excision, if they were up to date with the literature and research in the area, they would understand that in this group of women, the standard treatment does not apply. Okay, so far we've defined clinical reasoning and therapeutic reasoning, and we've applied a framework of questions mirroring that of informed consent to facilitate these reasoning skills. Let us look now at two teaching strategies that can be used to facilitate therapeutic reasoning in our learners. Let us begin by reviewing a method I introduced in our last session, the SNAPS method. This is a method that needs to be taught to both the preceptor and the learner. It is initiated by the learner. The learner begins by presenting a selective case presentation. They summarize briefly the history and physical findings. Then they narrow the differential to 2 or 3 relevant or likely possibilities. They analyze the differential by comparing and contrasting these possibilities. They then may probe the preceptor by asking questions about uncertainties, difficulties, or alternative approaches. And then they present a plan of management for the patient's medical issues. Finally, they select a case-related issue for self-study. Another strategy that can be used is chart-stimulated recall. Typically, the learner sees the patient, presents the case to the preceptor, and then discusses the patient before deciding upon a final treatment recommendation. However, there are times when the learner has seen and managed the patient on their own, and our case discussion is removed from the actual patient encounter. Such situations may arise with a senior learner at the end of a clinic or at the end of a call shift. Or perhaps both of you have been very busy managing patients throughout the day and/or clinic and may not have time for an in-depth discussion about management during the clinic. In this situation, you may want to say to the learner, "Let's discuss this case in more detail at the end of the clinic." It may seem artificial to discuss patients that have already been managed. However, revisiting cases when there is no time pressure to get the work done can be a very valuable teaching opportunity. Chart-stimulated recall can be done informally, where you sit down with the learner and the patient's chart and then ask them to walk you through the case and think out loud while they discuss the case. Or you may use a more formal template to review first the chart on your own, record your observations and comments, and then meet with the learner to discuss this case. The general steps are to select a case, review the note, Ask guiding questions around the case and provide verbal and/or written feedback to the learner. One example of a template that can be used to facilitate this chart-stimulated recall exercise is this worksheet developed by the University of Alberta Department of Family Medicine. The worksheet includes different areas of patient management and specific questions that can be asked the learner regarding their patient management. Preceptors are encouraged to review the chart note, choose a few discussion questions, record their observations on the chart, and then sit down with the learner to discuss these observations and give the learner feedback about how to improve not only their management, but perhaps their medical documentation of that management. What are the advantages of chart-stimulated recall? Well, first, it can be used to assess diagnostic and clinical reasoning. It can pick up premature diagnostic reasoning as well as inappropriate management choices. By asking in-depth questions around the learner's management of the patient, it can facilitate diagnostic and therapeutic reasoning skills. It also focuses the learner on patient-centered care. Finally, it assesses medical record keeping, an important communication skill for physicians. A demonstration of this process can be seen online through the University of Alberta Practical Prof website. If you are in the Fred Bryan's Master Teacher program, it will be loaded on your webpage. So the take-home points from today's highlights are that again, you can use a framework or a series of questions to guide a learner through the steps in therapeutic reasoning. This will help to role model the informed consent process. You can encourage the critical thinking about management and self-directed learning using the SNAPS method. And finally, you can use chart-stimulated recall to assess clinical reasoning and the documentation of that reasoning. So this concludes our 2 sessions on clinical reasoning skills. Our next session, session number 5, will be on direct observation of learners.